Hey everyone, welcome back to the Layback Podcast. Joining us today now is Layback veteran Dr. Matt Fury. He previously came on an interview way back when, first kind of run of podcast episodes. You might have been a first 10 or so guest. So it's nice to have you
Wow.
back on now for, I think, what's going to be episode 116. We've done a
Good for
couple of
you.
wraps. Thank you. We've done a lap or two around the sun since we last spoke officially on this
Yeah.
recording, but of course we had you back to host some of those Baseball Rehab Network kind of group discussions, panel discussions.
Yeah.
So it's been wonderful to continue to work together, grow in the space, and really seems like the best time to have you back on with some more advancements going on in the medical side of baseball. So who better to talk to than a surgeon growing in the space? And thank you for making time in between your busy schedule, especially with it being championship season now at LSU, and then
Yep.
in the LHSAA or whatever the abbreviation is. This isn't this like state championship week for baseball,
Yeah,
I'm
they
not
just wrapped
mistaken.
up.
Oh,
Yeah,
okay.
they just wrapped up last week. So a lot of action going on. But no, this is great. Thanks for having me back on. And congratulations on 160 plus episodes. I mean, I don't know what there was a stat a long time ago about how quickly podcasts die. Not that I didn't believe in you, but I don't think many people get the kind of staying power to get up to 160 and beyond. But I think that's just a credit to what
Well,
you've been doing and the interest in this, right? Like, people are
appreciate
interested
that.
in learning, and what
Small
you been.
correction though. I want to stress the correct syllable is I do plan on getting to 160, but we are at 116.
Oh,
Uh,
116. Well,
small
160 and you're
difference.
60s in the future. You got this. Once you get over 110, it's all downhill.
Yeah, that's kind of what it feels like. No, but seriously, it is funny. I keep telling myself, because I'm pretty sure that line of demarcation is like 10 episodes, or at least at one point, if it was like if you do more than 10 episodes, you're in the top 5% of podcasts ever produced. And then if you
Yeah,
eclipse 50, you're in the like top 1%. So at this point, I don't know. Like if I can call myself a one percenter in something, that's pretty cool. I'll take it.
I think you are. But look, the game's not going away. Unfortunately, the injuries we're trying to get them to go away, but they're still around, and the interest is not going away. And so I think this is a critical space that you fill. So
Well,
congratulations. That's
thank you.
awesome.
So that provides a decent segue. If anything, it seems like the interest is rising in the space, especially when a player with the caliber and notoriety of Tarik Skubal goes down with an injury. And I use goes down, I guess, kind of gingerly, because he never really went down. He didn't have a true injury. He just had something that was bothering him. And it sounds like that's bony spurs or something in the back of his elbow that was causing discomfort here and there. However, there's been news to come out that he's already back to a return to throw program, and he was only down with surgery 2 weeks ago. And it sounds like what was used in his operation was something called a nanoscope, or Boris is calling it now the Skubal scope. I don't want to give that too much credit right now as they're trying to make some money and maybe marketing rights off of a surgery. That's something different for me. Rebranding surgeries is very odd in my opinion, but hey, somebody's got to do it. I don't want surgeries to become more popular, but next thing you know, kids are going to be asking for the Skubal scope for the holidays, and that's not ideal.
It's not
But
ideal.
yeah,
Yeah.
so back to the task at hand. What is this nanoscope? When was this developed, and what can you share with us on it?
Yeah, no, it's a good question. It's always interesting for me when these episodes come up. Obviously, you never want a player to go down with injuries. You certainly don't want to see a player of his caliber at this time in his career and contract, all the other, and he's just so good for
Thankfully,
the
you
game,
did
right? You
sign the
just never
contract.
want. Yeah, we did sign it, but you never want to see this happen, right? At any level, but especially to a guy like him. But it is interesting though, because it stirs up interest. It stirs up interest within the lay community, and you get some reporting that sometimes I worry about what comes out from managing expectations. But situations like this, I think, highlight just pretty cool stuff that's going on in the world of orthopedics and with regards to innovation. And I think that this is this is a utilization of technology in a way that makes a lot of sense. And it truly is incrementally improving care and how we take care of folks, right? And I think that that's important because sometimes the sensationalized stories that come out aren't necessarily really something new or aren't something that truly moves the needle. It's just the way that it's presented. And then you have to manage that with patients or amongst the community. But for this, I think this is a meaningful thing. And it's interesting. And it's cool that it generates interest that people want to talk about it. So to recap, or I guess to rewind a little bit. So I obviously don't know his case intimately and can't speak about patient details in any sort of way, but posterior compartment issues happen in throwers for a multitude of reasons. And sometimes they're isolated. Sometimes it's in the setting of prior medial elbow stuff, medial elbow ligament issues starting to overload the posterior compartment. However, there's a lot of just generalized kind of bone spurs and arthritic changes that happen in the elbow, and guys can develop just isolated posterior compartment concerns. You can chip off a bone spur, have a loose body in the back of the elbow that can become symptomatic and can cause mechanical symptoms. Guys will have locking of the elbow. They'll feel like it'll lock or catch on them. And if that's the case, sometimes what you need to do is remove that mechanical piece, loose body, whatever it is, that mechanical insult to the back of the elbow. And we've obviously transitioned from open surgeries to arthroscopic surgeries over time, and the arthroscope being a meaningful way to cut down on the morbidity of some of these operations and to make them less invasive. They're minimally invasive, opportunities to use poke hole incisions and to access areas of the elbow that previously you had to do much bigger, significant surgery to get to. Now, that being said, there's still surgical trauma that occurs anytime that you put a scope in the elbow or the shoulder or the knee. And what was used in this operation is what's called a nanoscope. Technically, it's the Nanoscope 2.0. And that's a new development by one of our partners in the industry, Arthrex, who has seen the opportunity to improve on arthroscopy, because arthroscopic equipment, when it came to the US, was a big deal and changed how we took care of people. But then it largely has been relatively unchanged since then, right? We have not.
And how long ago was
really
that?
changed.
Just to interject real quick, Matt, I apologize.
Oh, I'd have to go back. It started over in Japan. I would have to go back on the actual date range for that.
Okay.
But I mean, we're talking about this was in the days of Jack Houston, and Jimmy Andrews was kind of working with Jack Houston at the time, and then it was sort of also one of the early adopters and utilizing this in the practice. So we're talking over the last 50 years of sports medicine, right?
Okay.
But the instrumentations the instrumentation has largely been unchanged. We still use, for the most part, the same size scopes, the same size instruments with some variations. But the nanoscope was a development to essentially decrease the diameter of the arthroscopy equipment so that you can access areas of the joint, sometimes simultaneously. You can use a regular scope in one place, a nanoscope in the other place, see things from other directions. But in this case, it was used to just have less soft tissue disruption and less fluid utilization to make this as minimally morbid as possible for his elbow, which there's a lot of stuff that we do in surgery that has been geared towards taking care of the soft tissues, being as kind and gentle to the soft tissues as possible, because for somebody like Skubal or these timelines really matter, and we're looking at how quickly. Everybody's always asking, when can he start throwing? When's he going to be back on the bump? And these little things that we do intraoperatively, I think, matter. And so the nanoscope allows for a smaller incision, a smaller poke hole. There's less fluid that runs through the joint. As a result of that, there's going to be less local inflammation inside the joint. And that's after the surgery. That's what you do, is you're trying to get the joint to settle down, get the range of motion back. Once the joint has now become quiet and you're ramping up your strengthening, then you can start from a throwing standpoint. And so the goal is trying to essentially cut down the timeline for that. But I think this unique new arthroscopy equipment does serve an important role for trying to minimize the morbidity. And there's other things that you do with regards to managing your fluid pressure and fluid volumes and being very surgically efficient. So trying to not switch portal sites, and because every time you're bringing the instrument in and out of the elbow, you're causing some even just low-grade surgical trauma while doing that. And so I think these are the things that we think about when we're trying to really be as efficient, as effective as possible for our patients.
From what I understand in my very minimal research, but of course I can use Google and AI like anyone else can. It sounds like this nanoscope technology in some cases can help with diagnostics beyond just the actual operation if an MRI doesn't give us the perfect view. But
Mhm.
in this case with Skubal, do you think beyond trying to minimize the morbidity, I like that phrasing from you a lot, by the way, that makes sense. I think the
Yeah.
layperson can grasp that, and that's kind of how I view myself in this situation. Do you think they elected to use that technology also because they had a good idea of what the case was that they were going into? From my understanding, it seems like you might hit some limitations with the nanoscope. On the other side, like the size is great because you're
Mhm.
minimizing the trauma and the fluidity and the morbidity of the whole situation. But also because of the size, you might not be able to perform the same tasks that traditional arthroscopic tools may allow for. Is that fair
Yeah.
to say from just the
No, I think
basic
those are
research I
good.
did?
No, I think those are good points, and I think they even mentioned that in the article that was published that Dr. Elatrosh had spoken about this as a tool, but that he'd have all the other stuff available if he couldn't access the compartment that he needed to, or effectively execute what he was trying to do. He'd have all the stuff available to him. But a couple points. I mean, you bring up, yes, there's a role for utilizing this technology in other situations that we haven't done. So diagnostic arthroscopy can be done in a less invasive fashion. There are some now in-office procedures that can be done outside of the operating room that may be or ways to address meniscus or other pathologies in a treatment setting, not just purely diagnostic. The decreased morbidity that is associated with that is helpful. So there's other utilizations. I think this type of stuff is just gonna grow in its application over time. To your point, there are some limitations. However, smaller instrumentation I think is likely the future here. Just from an access standpoint, I think you have more issues surgically sometimes accessing things because of size of instrumentation and tightness of compartments. I think that's often a bigger problem. So I think there's probably going to be an increasing role in smaller instrumentation, flexible instrumentation, other things. I think that's probably the next wave of surgical intervention. But the classic is the classic because it works, though. Like the OG works, and so you can have it as a backup. But I think there's going to be kind of an increasing role in some of this stuff.
Before young athletes who have an elbow injury go in asking for the same procedure as Skubal, what do you think the general population needs to understand? It sounds like you've hit on a couple of these points. Like we know this was a bone spur situation, or at least that's what's being documented to us. It was posterior compartment. What hesitations or I guess what knowledge do you encourage the individual to have, the potential patient to have before they walk into an office with a hurt elbow and say, just give me what you did to Skubal?
Look, it's a very valid question. I think the biggest thing is that you've gotta be confident in the diagnosis, and the treatment plan is tailored by somebody who's doing this a lot and is really thoughtful. Because just even in this case here, and again, we don't know any details, but whenever I see a posterior compartment issue, it makes me broaden out first. It's easy to see a loose body in the back of the elbow and say, look, we got to get that loose body out of there. But that is really not the appropriate, workup. And I'm sure that that's what he went through too as well. You're getting a great physical exam, evaluating the ligament or prior graft immediately on exam, trying to assess what proportion of their symptoms are coming from the posterior compartment based off of bounce home testing. What's their overall motion look like? Looking at their imaging, again, because you don't want to treat a problem in isolation when really it's in the setting of something else, right? It's in the setting of a ligament that is ailed, or prior ligament tear, or an osteochondral lesion in the capitellum, something else. My point is, you want to be comprehensive, you want to be thorough. And so, as opposed to patients just going and seeking out technology because that's what they want, I think they need to seek out expertise, because the technology is a tool, right? And I think it's a nice tool, it's a useful tool, but it's not the only way to do something. And there's been a lot of great surgery that has been done and continuing to be done not necessarily using. And so I think you need to seek out the expertise and not necessarily the tool, because I think that's what gets some people in trouble. And we've seen that with UCL repair and stuff too, right? People come in requesting repair for various reasons, and it might not be the best move for the patient. And so that's where I think you gotta be confident in who you're talking to. You got to arm yourself and educate yourself too as well. So then you're prepared to have a conversation, ask the questions that you want to ask, right? And that's the best way to get your treatment, not necessarily seeking a certain technology.
So what it sounds like, if I can kind of play translator here, what we need to do is address the specific problem at hand. It's not that we're trying to treat a symptom. And I'm glad you've brought this up a couple times now. You've mentioned, in this case, being able to address a loose body and based on our assumption. Granted, we don't know anything specifically of what Skubal has gone through. We don't know his history. We don't know what the imaging presented, but we can assume based on their course of action that there wasn't additional gapping at the medial elbow. The UCL seems to be intact. The flexor mass seems to be intact. So they were able to address a very acute area, as opposed to what you have said now, and I'm grateful that you have addressed it, is oftentimes these posterior issues, however the pain manifests, often come from something that was born at the medial elbow. So additional gapping at the medial elbow has then led to compression on the posterior side. It's led to the banging. It's led to compression, bruising, swelling. And a lot of time these osteophytes happen because the medial elbow is unstable in some capacity, correct?
Yeah, I think, look, you just can't live or work in isolation. And that's the medial elbow supports the posterior compartment and vice versa. We talk about the flexor pronator mass a lot, right? Flexor pronator mass sits on top of the ligament. And we think about these injuries, not really just like a ligament injury. It's like a flexor injury. It's a ligament plus flexor complex. Everything is interrelated. I just think it's important to have a really holistic view of the thrower, of the athlete, of the pathology. And that starts with a good history and a good exam, honestly. And then the imaging obviously helps hone that in. But I think that's why it's important to seek out expertise and not necessarily technology, because the expertise is going to evolve. If they're really at the top of the game, if they're really trying to push themselves to be better, we're going to look for new technology. We're going to look for new ways to do things to try and solve clinical problems. I think from the patient standpoint, you just got to find somebody that you trust and has a good track record and really lives and breathes this stuff.
Speaking of evolutions, another seemingly more basic one, rather than the introduction of an entirely new technology of the nanoscope, is the way that MRIs are now being performed on baseball players' elbows, or really throwers' elbows in general. And that is commonly being discussed now as the fever view. So can you please take us through what a fever view MRI is?
Yeah, so great question. I'm a big fan of the fever view and utilize it routinely in practice. Fever stands for flexion elbow valgus external rotation. So it's a special MRI sequence that was developed by Pam Lund. You go through your standard MRI series or sequences, and then you position them over a bolster with a bolster underneath the elbow and a sandbag over the wrist. And so it's applying a valgus stress to the medial elbow. And then the radiology tech, when they're setting up for the scan, orients the planes so that it's set up. It's a coronal series that goes through the plane of the ligament. So it's not just the stress view, but also they pause and readjust how they go through the elbow, and it's specifically oriented along the plane of the UCL. And so I think there's multiple benefits to this study. I think the most important benefit is that the view of the ligament it's beautiful. I mean, when you reorient it in plane plus with the stress applied, you really get a great view of the ligament quality, its integrity. And sometimes you get these tears that have, well, I guess let me back up. The tears can happen in multiple different types. They can tear fully off the bone, distally at the sublime tubercle. They can, tear fully off the bone proximally off the medial epicondyle. Sometimes you get these mid-substance or delaminating tears. And there's a couple different variations along the way too. The ones that tear off the bone, that the ligament's totally blown up, you can see that on your standard traditional MRIs, and that's not always the issue. But sometimes you get some of these delaminated tears where it's a kind of split in the intersubstance, and the tissue is still sitting on itself, kind of reapproximated. But then you put them in this fever view, and you put a little bit of stress on the medial elbow, and just that stress trying to tension the ligament will show or expose some of these delaminations. I think it just gives a really, really nice view of the ligament for understanding. In their study, when Pam Lung described the sequence, they showed some of the diagnostic data with regards amongst multiple radiologists on tear characteristics and things. Now, there's another, aside from it being a pretty picture and a great evaluation of the ligament itself, you also get some objective data too about the medial joint space, like the ulnohumeral joint gapping. And that's the part for me that is potentially very useful, but not all the time. And the reason why is because if you don't know where the thrower started, then it's hard to really make much of the number, because we've seen throwers with a millimeter of gapping and they're having pain. They're still having pain on the medial elbow and having a hard time throwing, while they've had others that have had multiple millimeters of gapping and still throwing at a very high level. And so just like anywhere else, just like everybody's shoulder stability feels different, everybody has some element of difference in their ACL exam, I think the medial elbow is different. Okay. And some people are a little bit more lax, while others are wound up a bit tight. And we know from prior ultrasound data that the UCL is not a static structure. It dynamically responds to stress, right? And so we've seen from the Chalmers and their ultrasound data about how the ligament thickens and becomes more lax over the course of the season. So there may be changes throughout the year with regards to the fever view, right? Beginning of the season versus the end of the season and things. So if you have a baseline value of stress with joint gapping, I think that's really helpful, because then you can say, look, it was 0.8 millimeters and now it's 3.5, right? That is something that you can then correlate and say, look, your medial elbow is lax and no longer providing the stability to the medial joint. However, if you don't know where they started, I think it's hard to necessarily anchor on just a number, but that's fine. Because I mean, again, most of this is history. Most of this is physical exam, and then the imaging just kind of takes us home.
If you were given the right to, I guess, create the rules for MRI diagnostics across the board for the entire industry, would you force everyone to just do a fever view if they're coming in with medial elbow pain? Is there any purpose in not utilizing the fever view at this point?
Well, so it is another series. It's time in the scanner. And so for some institutions, or especially if it's high volume or they're trying to fit people in, that's another, if you add up, if you're doing a whole bunch of elbow MRIs a day, that can add some time to it. But and you have to do it well, right? To get this value from it, you have to do it well. And look, there are some poorly done fever views that come in and you see them and you're like, still out of plane of the ligament, that's not as beneficial as I love to see it. So it still has to be done well. But in general, though, I love it. I love the data. Keith Meister really was sort of early adopter here, and was one of the ones who kind of was talking about the utility of this. And I think that's just continued to grow. And I agree. I mean, I love the view of the ligament. I like having some of the objective data too, as well. And I'd like to see it if I can, but not everybody comes in with that. And like, we can still read MRIs and diagnose people just like we always have, but I like it.
Okay. Yeah. I know you can't say anything too strict. Obviously, people have to have the schooling or the teaching to get better at these things. But again,
I think
I'm
a
here
well-done
to
fever view
extrapolate.
a well-done fever view is very helpful. I don't think it's the end-all be-all, but I like having that data. But again, if kids come in and they've had an MRI done elsewhere and it's a well-done MRI and it syncs up with the exam and clinical history, I'm not making everybody go redo it.
Right.
But there are some times where they come in and the MRI is maybe non-diagnostic and their clinical history and exam is more concerning. And then that's what I say, hey, look, we're going to repeat your MRI. And in particular, this time, we're going to do a special stress MRI in conjunction with it. That can be helpful here. And sometimes that will sort of unmask some things that weren't appreciated previously.
I believe we might have talked about this way back when, but it's so hard not to discuss it when we're speaking of technology, with kind of the theme of don't fix it if it ain't broken. Arthrogram just seems to be a fantastic way to diagnose partial tears. It's been well documented in the literature. What's the reason that with newly developing MRI technologies, arthrogram, the use of dye is able to kind of stay strong as our best diagnostic tool for partial UCL injuries?
Yeah, I think that it's an interesting question. I'm smirking because I'll give you a little background in a second. But to your point, though, the literature would support, especially these partial sprains, that the dye improves the diagnostic ability of the study, and that's because having the dye in the joint will sometimes elevate that distal ligament. You'll see that classic T sign if you Google image what that looks like, and that's just some undercutting of the dye underneath the distal ligament where it attaches to subline tubercle. You may not have appreciated that on a previous MRI. I trained at HSS, where Hollis Potter in the radiology department there is very well respected, well established. We never did arthrograms on anything. It was kind of like that was just not the way, because the thought was with the way that, and there's a couple unique ways that we did our MRIs. You'd have your fluid sensitive coronal drive through, and then your proton density other series to show the anatomy better. And they felt like with a well done MRI with good equipment and well protocol, that you can see all the stuff that you need to see. And because the dye can kind of blur out some of the other things, though. Sometimes the dye can overpower some periligamentous edema, or understanding kind of how much the flexor is ailing. So for instance, if they put dye in the joint, they've got a ligament injury that extravasates into the flexor, you can't really tell how much of that's dye versus some edema throughout the flexor. So it's not perfect, but it does help diagnostic quality on some of the partials and in some of the not as well done studies, if that makes sense. It probably raises the floor, right? But I think at the ceiling of well protocoled, well performed studies that are being interpreted by folks that are either looking at a bunch of UCLs or radiologists that are musculoskeletal, specifically elbow, I think diagnostically over there, it's probably about equivalent, if that makes sense.
No, that's super helpful, because we are in a position where, as you know, athletes are coming to us all the time, especially those with elbow pain. That's why most of the time they're seeking out FlexPro Grip, where they're trying to figure out what to do diagnostically. They don't have an answer for why their elbow hurts. And we aren't in a position to provide medical advice, but oftentimes all we can do is rely on the literature, give people the tools that we have access to or the studies we have access to. And of course, we try to lean on people like you as much as we possibly can. But if they're not going to fly down and see you in Baton Rouge, or they're not going to ship a copy of a disc and send it off your way, we're often trying to tell them what's going to give them the best reads. I mean, that's education for us. That's education for me.
To your point, you don't know where they're getting the study. You don't know what the quality of the study you're going to get to. And I think that's where the arthrogram can sometimes be helpful for some of the variabilities in imaging technique and quality. But it's not an absolute, but it can be helpful. I think it's hard for the position that you're talking about. And obviously we've seen some of these guys, and I love trying to help as best we can too, but sometimes you see the MRI comes in, you're like, this is a poorly done or non-diagnostic MRI, and then you got to try to help them get in the right direction and get another study, or get an exam. It's hard from the virtual consult type of thing, and that's why you got to see the player and examine them, and it's another data point that's as important as anything.
So we've covered a couple different diagnostic measures or new surgical tools. We'll re-anchor in the surgical space now, and that's kind of now to talk about the popularity of hybrid reconstruction. That gets mentioned all the time here on the Layback Podcast. Probably starting with a strange question, again, asking you to rewrite the way protocols are used across the board here. If an individual meets the requirements for a full UCL reconstruction, why wouldn't you just do a hybrid at this point?
So it's a good question. What I'll tell you is that the hybrid reconstructions are rising in popularity. There's no doubt about that. At the kind of upper echelons of sport, professional level, and that's really sort of taken over the last 10 years or so and continues to rise in popularity. And a lot of that's done. Look, we're standing on the shoulders of giants and the people that are continuing to innovate. And Keith Meister has done a lot of work here with regards to trying to address the revision problem. That's really how it starts. And I think it's probably helpful, right? If you rewind and say, okay, well, then why were we innovating on a surgery that's been pretty good? And because I would say our historical lens of the surgery, yes, it's been pretty good because guys, previously this was career ending. And then we now had a tool that got them back to restore careers. But like we've talked about before, granularly looking at what does that mean to return, we could always be better, right? And yes, maybe they're returning to sport, but were they really returning to their prior level of performance or their desired level of performance? And that's a totally different conversation, right? But at the same time, the game has evolved as well. Rising spin rate, pitch design era has really changed how these guys train and what pitching looks like. Like turn on a game from 1970 and look what it looked like, and turn on a game from now, and it's like, you might think you're watching some aliens play ball with just the velo and the movement and everything. But because of that, there's been rising concern with regards to the longevity too, as well, of some of the traditional reconstructions, because guys are throwing harder and spin and all the other factors. And we know that revision surgery does not fare as well, right? If you look at the return to sport rates, there's a recent study over this past year that also kind of re-looked at it. It ends up being around the 70-ish% line. But if you're looking at return the same level, it's in the 50s. Performance stuff probably in even below. So we're not doing as well as we would like to do in the revision setting. And because of that, we've then focused on, okay, well, how are we trying to prevent revisions? And that's where the hybrid sort of came to be. And a lot of it was, again, by Dr. Meister and a lot of what he was doing and thinking and trying to innovate here. Why shouldn't everybody get a hybrid? I think that just goes back to where is the data currently sitting? And there's biomechanical data that shows that the addition of suture augmentation reconstruction is biomechanically favorable at time zero. So strength, gapping, and things like that, there are advantages to it. The clinical data has not necessarily been shown yet, has not really been published yet per se. There have been clinical series that have been presented, and there's certainly a track record that we've seen kind of bear out in the game and in front of us. And so I think that over time, as more data then shows with the hybrid type reconstructions, our return to sport rates are where we think that we are, and our revision rates are trending in the right direction, I think you're going to see more and more adoption. Now, that being said, there's a push coming from the game too as well. Guys are asking for it too. They want it's stronger. Biomechanically it says it's stronger, so I want something stronger. And so guys are requesting it too. And so I think that's another factor that sort of pushes to innovate into the evolution of this surgery. I do a lot of hybrids because I think there's a lot of benefits from taking this multi-layered approach. Like if they've got ligament tissue there, I'm going to go ahead and repair it back down to the bone. Makes sense, right? And then if we're going to do a ligament repair, we're going to reinforce that with the internal brace to give that a support while that native tissue is healing, and then putting a graft over the top. And I think there's benefits to the various timelines of native tissue healing while being supported, and then a graft reincorporation, and the ligamentization process of the graft occurs over a longer timeline. So I think there are biomechanical advantages. There are likely some biologic advantages that inherently make sense but have not been shown. And the clinical advantages I think we're seeing but have not necessarily been published yet. So long-winded answer to say I think we're early on the curve, but you're going to see it more and more. But the answer is why not? It's because, look, there's some times where too strong is not necessarily the answer, right? There's times in history where we've done things that are too stiff or too strong, and there are some downsides to that. I don't think that's the case here, but that's the people that are sort of hesitant to embrace this technique are probably just waiting to see some more data.
Potentially strange question here from, again, someone not in the medical field, but someone that tries to consume a lot of information. I have heard in very small camps an apprehension surrounding load not necessarily going through the native tissue or the new ligament that you put in, so the tendon graft, but the internal brace being so strong that the load is then being handled by the internal brace or the scaffolding around that tendon graft. Are those apprehensions valid? Why might someone be concerned in that setting? As you said, there aren't clinical trials at this point with longitudinal data to look at what might actually happen to the
Yeah.
replaced ligament. But before I just continue to talk out of my ass, is there a reason for that fear?
Well, no, I mean, it's definitely valid, right? I mean, historically, there have been artificial ligament type implants in the past that have not had good clinical track record for foreign body reactions or other things. Now this technology has been utilized elsewhere. It started in the ankle and it's being utilized in other forms of the body and have not seen those same types of foreign body reactions. But there are a couple of concerns that start from joint loading, and can you just over compress the joint and point load or increase the load of the medial elbow if it's too tight. That's been tested, at least in the repair setting. Dr. Dugas and the ASMI folks, they tested that in a UCL repair model and showed that you don't over tighten or over compress the medial side, but that's sort of one of the concerns. The concern for stress shielding the underlying healing structures is also certainly valid too, and we see that in other areas of the body. That the problem with that is it's very hard to test. We don't really have good load bearing, load sharing, load stress shielding type models that you can test in an animal setting. That's just something clinically you have to follow over time. But there's so many variabilities in how people do this. It's hard to really extrapolate that. But I think that's a valid concern. Because of that, though, the way I do this, and I think the way some others do this too as well, is in the order of tensioning, and you're trying to make sure that your underlying tissues are still seeing the load and that it's not all picked up by the internal brace or by the suture. So for example, in a hybrid, I'll repair the ligament and then as you bring the brace and the graft up into the tunnels, we'll tie the brace down first and then tie the graft. So the brace essentially sets the joint line. And then when you tension the graft, that's the last thing being tensioned. So you know that the graft is seeing stress, because if you were to theoretically tension that brace second and a lot tighter, then the brace, all the stress is seeing is being seen by the brace before it's seen by the graft. If that makes sense as I describe it. But I think those are all very valid concerns, and that's also why technically we do certain things in a certain manner to try and alleviate some of those concerns. But look, it's the structure of the suture. There's some creep that's going to happen in there too as well, and it's not just a static structure too. There's at least some lab, Gus Mazaka's lab, they demonstrated that with the fiber tape, which is what it is, putting it in a milieu of some of the stuff you'd see at the time of surgery, right? Some of the, with bone tunnels and other things, they put BMAC and PRP and some other factors around the fiber tape. And they showed that there was increased sort of adhesion of some of the osteocytes and ligaments, all these cell types that are going to play a role in the healing. And so clinically, though, I think we see some of that as well, because if you go back in a revision setting, and whether you're revising a repair to a reconstruction or doing a revision of a prior hybrid, when you go down and you get to the area of the fiber tape, there's often just a lot of thick tissue around it. And that may be demonstrating that there is also a biologic event that happens around the tape too as well with regards to adhesion of some of the cells. Long-winded answer. There are still some concerns, but I think there's increasing utilization and there's some good evidence that's building for it. It's just not all packaged up, but a lot of the athletes aren't willing to wait for the whole package, right? Because their career is in the now, and their concerns are regards to timelines and with regards to revision rates and all these other factors. And so I educate them in my office, hey, this is how we're doing it for your tear. I would do a hybrid reconstruction. These are, I think, the potential advantages to it. These are some of the downsides. And, we make an informed decision with regards to that. But long-winded answer, but I think it's not going away anytime soon.
Clarifying question here. When you mention those biologic events at the site, are you viewing those as a positive response? Are we pleased with that from the surgical standpoint?
Yeah, it's a good question. And generally I am, because you're asking for that tissue to incorporate. You're asking for the tissue to mature, and you know that you need some durable tissue on the medial elbow to withstand the stresses that we're asking of it. Now, but to your point though, sometimes you can have an overabundance of healing, right? We see it in other places, you get too stiff, right? You do a stability surgery and then the knee or the shoulder's too stiff, and then you have to work through that or maybe do something else. So there's probably a Goldilocks there. However, in general, I think it's likely beneficial.
And you said, to my point, I actually was more at the more from the point of view of just an extreme search for knowledge.
Yeah.
Like when I hear there's a biological event occurring, to me, it's like that's exciting. It means there's some sort of healing that is happening. Now, I don't know the ramifications of that healing, but to me, it at least sounds like the brace is being accepted as biological tissue at that point, or the body is actually trying to utilize it as kind of this buttressing system as opposed to a true foreign body.
We think it's helpful, but we don't totally know that, but we think it is helpful. And that's also, been shown now. And then if you take it the next step with some of these, when you have re-tears or some of these injuries that have occurred in the setting of a prior reconstruction or a prior hybrid, oftentimes you have good tissue available to then do a graft repair. So to go and repair the underlying tissue back down to the bone and then support that with a suture augmentation or internal brace. And so I think having tissue there to work with is more helpful than not typically.
This is fascinating to me. I feel like I'm getting to nerd out. It's really exciting.
This is the stuff that makes us excited. And I had the opportunity when I was in Dallas a couple weeks ago, LSU gymnastics, when they were competing for the national championship, I went and spent some time with Dr. Meister over there on a Wednesday, and just got to sit down and talk about this stuff that he's fired up about, and we sat over in the surgical lounge and just nerd out about this stuff, nerd out about the flexor tendon, about the ligament, because I think that's what you want, is like you want people that are going to bed at night, putting their head on the pillow and trying to think about how do I do this better, right? We got to be better than what we are. Sometimes it's you wake up at 2 a.m. You're like, you know what? I think we need to look at this. I think we got to be a little better with how we're handling this part of the tissue. And some of the innovation happens there when you're not sitting there thinking about it, but because you're obsessed by it, or it's really part of what you care about and part of just you internalize this pursuit, that it happens at random moments. And so I think that's the kind of stuff that you want to see. And that's why I love talking to you guys too, because you live and breathe this as well. And we have different perspectives and different viewpoints of it. I think we can learn a lot from each other. The more we talk about this, the more we learn from each other.
I know that was a theme the first time we had you on, was talking about the collaboration that actually needs to occur to further improve the recovery rate. So we don't need to beat a dead horse on that one, but I love that you are passionate about that in bringing in rehab professionals. But what I want to ask is if there's any dirt that you can share from the little coffee talk that you and Dr. Meister might have had, because that's a true meeting of the minds. Is there anything that the industry can accept a little teaser on, or a little breadcrumb out here in the atmosphere of what might be to come next? Like, what is keeping you guys up at night?
No, what I think that he's obviously brought a lot of interest to the flexor, and that was a lot of our conversation was focused on the relationship between the flexor and the ligament. I think that that's just becoming a bigger and bigger point of emphasis, and a lot of these injuries are really flexor injuries. We've been talking about the ligament for years, but it's the ligament flexor complex. And there's some studies in Japan that have shown histologically that relationship between the common flexor tendon and the proximal ligament. And I just think that's where the future is probably, is how do we address the flexor? How do we support the flexor? That's part of what you guys are doing too. How do we test the flexor? How do we train the flexor? I think that there's going to be more and more and more emphasis on recognizing, treating, addressing, preventing flexor issues, because it's just as important as the ligament too as well. So, but like I was grateful for the opportunity to spend some time and pick his brain and learn a bunch too. But that was a lot of the takeaways. Like, how do we handle the flexor? And I think that'll be a point of emphasis that's growing over time.
This just popped in my head when you kind of bring up what we do and the relationship that we share. Do you think that there's a place in the examination room, for instance, that you're sitting in right now, to bring in more objective testing in the like the true medical side? Because right now it seems like the majority of objective testing, aside from the diagnostics, the actual studies that you talked about earlier, nanoscope, MRI, those kind of things. Is there a point to bring more data actually into the medical examination room?
I mean, for sure. I'm a huge proponent of that. Now, whether it's tested in the room per se, or if it's part of the workup as they're presenting for their appointment, I think
Okay.
it's a different conversation. But absolutely, I'm all for having more data, having objective data over some of the other aspects of clinical exam. Doesn't replace everything. But like, for example, some of the therapists that I work with very frequently on my throwers, like they know if I got somebody coming in, I'll get a text message, like, hey, so-and-so seen you later today. Here's some of their latest isokinetic testing. Here's shoulder motion. We assess their strength. Here's their latest flexor pronator numbers. As part of that's the history for me. So I go, they're in the room. My staff comes out and says, hey, so-and-so's back there. He feels pretty good. I pull up the text message. I start flipping through numbers, and I look and realize, like, hey, he's still lacking. He's made some grounds on his total arc of motion for his shoulder, but he's still lacking based off of where we knew his baseline was. Test strength is improving, not quite where we want it to be, but then it can come back. And I think the athletes appreciate that too, because you can have a conversation that evolves from, how are you? I'm good. Okay, you look good, versus how are you? I'm getting better. Yeah, I can see that. Your strength is up 10%. You're still not quite where we were previously, but we're making progress. And then they see that as a challenge, as a homework. You've got some objective numbers where they can grasp, and you're not just necessarily the bad guy saying you're not quite ready. It's more of a team that just says, hey, look, here's where we are. We know what the numbers are. We know where you can be or where you've been, and let's just take a couple more weeks. And I think it's really helpful. So I'm all for more data. And I think that scenario is great if you have it set up, but that's not always practical though.
Well, I appreciate you sharing that. Like that stuff excites me. That stuff really excites me because that is how we can continue to be involved and I think grow as an industry together, right? It's I hate when we're stuck in silos. I never want to be in silos. The only way that we're ever going to chip away at this problem is if we're arm in arm trying to march towards
Yeah.
the same goal. But as we near the top of the hour here, we're kind of coming to a close with what we have in our schedules. What have we missed today? What else is exciting you, or what's on the horizon that you can share for us?
We could do this all day. It's unfortunate that the timer is winding down. I think that we're just going to continue to evolve. And I think that there are multiple directions in which this is going to go. I think we're going to continue to understand the implications of training the flexor, assessing the flexor, training the flexor. I think that surgically, we're going to see the hybrid data over time. I think it'd be interesting to do what we've done in the past with everything else, right? Seeing the return to sports stuff and seeing the performance-based things, how advanced analytics are evolving on the return, what those timelines and the times to recovery look like with the hybrid. I think there's also a question about, can we improve the biology that we're working with too? Like, there's a lot of orthopedics where our implants are strong and our suture materials and all this stuff is stronger, but that's not necessarily where the delta has to be. That's not where the next change has to be. And it's the biology aspect. And there is some interest and pursuit in other area. For instance, in the rotator cuff, we're mainly focused on how do we get this thing to heal? How do we encourage the healing environment from the tendon back down to the bone? In the ACL, there's also some interest. Is there stuff we can do to the tunnels to make things incorporate faster? That's still early. We haven't seen definitive data, but there's interest in some early data there. I think we're going to see some of that as well with regards to the UCL. Is there a way that we can influence the underlying healing, the biology of the ligament in the tunnel, attaching to the bone? And is that the types of suture materials that you're using, the way that you prepare the bone? Is there stuff that we need to be putting in the tunnels? And again, that's far ahead of any evidence per se, but I think that's where you're going to see some evolution, is trying to address the biology. And I think you're going to continue to see this dance between performance and prevention, and how do we support throwers that are going to continue to go, and they're going to continue to redline and push the boundaries. And we're going to see guys throwing harder and harder, and spin rates just doing what they're doing year over year. And we got to figure out how do we recognize, intervene without necessarily getting in the way of guys. How do we support them from doing what they want to do, intervening when we know that or when we worry they're at higher risk of an issue, but also not affecting them from doing the stuff that they love to do. And that's an art, and that's going to continue to evolve over time.
That's a fantastic exclamation point. I went back on some notes that I had and like, oh shoot, I didn't ask that question. I didn't ask that one. But as you said, this is something that we could do all day. So maybe we'll have you on again sooner than 100-episode gap, and we'll revisit some of
we can
these
do
things.
it at 174. I'm free. No, look, I'll come on anytime. I'll talk about this stuff day or night. I think it helps everybody. I think it helps for patients to be educated. It helps for me to hear where some of the questions are going. I just think it's good for everybody. I'll be on anytime.
Well, I appreciate that, and I'm going to take that as gospel. I'm going to hold you to it. I'm probably going to call you here at 3 a.m. I'm going to be at a loss, not know what to do.
Let's do it.
Matt, like we need a
solution.
An episode right now. I can't sleep. But thank you so much again for your time today, taking it out of the busy schedule. Hopefully the Tigers can get something done here in the SEC tournament. For baseball, softball is on another great run. And of course, the track and field program is amazing at LSU as well. And if I'm not mistaken, it's also championship season for them. So
big time.
A lot of exciting stuff going on in Baton Rouge right now, and it's awesome that you get to be a part of it. So best of luck to you and the Tigers. Thanks again. And of course, to everyone out there, thanks for laying back with us.